Welcome to the Compounding Center Connections, where we talk about different health conditions with our partnered practitioners. I'm your host, Jay Gill, a compounding pharmacist from the Compounding Center in Leesburg, Virginia. At the Compounding Center, we collaborate with practitioners, create custom medications to help our patients get better. In this episode, our guest is Dr. Leonard Weinstock, a board-certified gastroenterologist, and your practice is in St. Louis, Missouri.
Right.
Dr. Weinstock is going to talk to about MCAS, also called Mast Cell Activation Syndrome. So welcome to the show, Dr. Weinstock. Could you please introduce yourself and your practice to the listeners?
Okay, thank you so much, Jay. I have been in practice for a long time. I started in 1987, joined a very busy physician who said, you should keep your mind open, have an internal medicine practice as well as GI, in part so you could refer patients to other specialists and get known. But it also keeps you well-rounded. And I always liked internal medicine. I thought these were the sleuths of medicine. These were the detectives. And I loved gastroenterology because it was like being a detective. Plus, you got to see things and do things with endoscopy that rounded it out almost to a surgical field. But when I got out, Jay, I realized I didn't know the first thing about most syndromes that they're talking about. I didn't remember being taught much about irritable bowel syndrome or fibromyalgia syndrome or interstitial cystitis syndrome. I don't know if I was sleeping in those classes or they just never approached it. And so I saw all these things in internal medicine, restless leg syndrome, chronic fatigue syndrome, that I was wondering, well, if we're so smart, why are we seeing everything with syndrome attached to it?
Well, Dr. Weinstock, before we begin, I really want to truly appreciate you. To the listeners, Dr. Weinstock is joining us for this episode on a Sunday at 4:00 on his vacation. So I truly appreciate it. And you have an expert or extensive knowledge with low-dose naltrexone and autoimmune conditions. And I've been to many of your lectures, and this is the very first time we're kind of meeting virtually, first time in person kind of. So thank you very much.
My pleasure.
Before we begin, a disclaimer that the information discussed today is strictly for informational purposes only, not for diagnosis or treatment. And so let's get started. So usually I'm fairly knowledgeable about a condition, but in this particular case, I have to be honest, I don't know too much about MCAS. So I'm looking forward to learning from you today in this episode. Could you set the stage for us? What do you on a daily basis, could you describe in a daily basis a typical patient that you see and you suspect MCAS?
Absolutely. Well, what I'd like to say is the very first patient who I diagnosed the condition was not somebody I diagnosed. It was diagnosed by somebody else. She called me up in 2016 for a consultation. She lived in Alaska. She was led through my door, so to speak, virtually by Linda Ellsgood, who runs the LDN Research Trust.org. And so Jill, I can use her name in part because she was the propositus of a case report, the first case report and paper that I wrote about MCAS. And she presented with abdominal pain, bloating, diarrhea, foggy, POTS symptoms, severe nausea, fainting, all these symptoms that we went back to ultimately and said, we've got to write this up because she was offered new treatment that had not been given before. And so that was my first publication, namely a case of MCAS and POTS alleviated by intravenous immune globulin, treatment of inflammation by low-dose naltrexone, and treatment of small intestinal bacterial overgrowth by rifaximin. And so not only did she make me aware of what POTS and MCAS was, because I wasn't taught those in med school, but I basically, with her initiative, helped cure her of her symptoms. And she went from 42 symptoms of 9 to 10 out of 10 severity with complete disability to a completely functioning mathematician, statistician, dietitian. And Jill is the most amazing person. She used to pass out when she went into big box stores. She said those were her kryptonites that weakened her, and she'd pass out. Fluorescent lights, change in atmosphere, things that you'd never think would be reasonable for a patient to come up with. How could they make that up? But the key thing is, whether it was somebody like Jill with 42 symptoms or somebody who had refractory nausea and was labeled with cyclic vomiting, or refractory irritable bowel syndrome, who happened to have hives, itching, rash, ringing of the ears, restless leg syndrome, pelvic floor pain. These are the things that make MCAS patients, along with two other syndromes, very common, namely the evil triad of MCAS, POTS, postural orthostatic tachycardia syndrome, and EDS, Ehlers-Danlos syndrome.
So, Dr. Weinstock, can we go back to the beginning and kind of could you talk to us about what is mast cell activation syndrome and what causes it? In kind of general terms, what is it?
Okay, it's an unregulated mast cell that has undergone mutation of the controller gene. So it's basically like a drunk sailor. It acts like it wants to. It spits out chemicals and which cause inflammation. The mast cell is the most important immune cell in the body. It mainly lives in the bone marrow, but what it wakes up, if you will, when there's been inflammation, infection, burn, injury, infection, leading to activation of mast cells and drawing other mast cells and other types of immune cells to the site of injury. And then normal mast cells will say, okay, you've done your job, time to quit. The angry, unregulated mast cell, because of its gene mutation, says, okay, join the party. We're going to keep on causing inflammation, and you guys can do whatever you want. So basically, we have like one set of your normal mast cells be active, and they activate other cells, in particular, other mast cells. So it's a cascading effect. So what do you get? You've got a wide range of systemic symptoms caused by activation of the mast cell line.
So the mast cells are released due to inflammation, or I'm trying to figure out what comes first. Is it the autoimmune that causes an amped up immune system to release it, or does the mast cell go are released and they lead to inflammation? Like if you could, like what comes first?
Sure. Yeah. Well, first of all, let's start at the very beginning. There's a genetic predisposition to develop the disease. So, a child who has colic, headaches, constipation, maybe food allergies, but they can also have other disorders, nausea, rashes, hives. These people, little people, have a mother most often who has undiagnosed symptoms and syndromes. So she may or may not have full blown MCAS. But then she gives birth to a child who then develops symptoms because of mutation of one of the cells in their body, namely one of the lines of mast cells. And that is in part triggered by our environment, so-called epigenetic phenomenon. So if you're exposed to radon or maybe pollution or maybe PFAs in the water we drink, it will mutate. And then once you get mutation, it stays. And these mast cells then pop out of the bone marrow, go to various sites, the nose, the gut, the mouth, the skin, the vagina, uh, the cervix, all areas of body, especially environmental surfaces, and they live for a long time. They can live months to years at these sites, creating havoc. So it's spitting out from the bone marrow, disseminating in the systemic area, but they're not becoming so badly in terms of so badly generated that you'd call it a cancer. That would be mastocytosis, a very rare cause of mast cell disturbance. But 17% of the Americans have mast cell activation syndrome.
Okay. Um, so environmental toxins are a trigger. Are there other triggers for
Yeah.
MCAS?
Oh, yeah. Well, first of all, you got to have the disease to get the triggers to be in action. So, in other words,
Yeah.
you got to have the mutated KIT gene, it's called, which is the controller gene. If,
Okay.
so, once you're set up with some of your mast cells like that, you've got the disorder. But of course, if you have, let's say, recurrent ear infections and strep infections as a child, A, that can activate things, and B, it might be responsible for mutations. Or you get, as a teenager, mono, and that viral infections will mutate or always lead to activation of the mast cells and get you in going into a stepwise worsening situation, just like we see in our mast cell patients who get COVID. And then that long COVID exacerbates mast cell activation, leading towards this condition. And I published a paper showing that once normal people actually get COVID, they act like MCAS patients, but they're truly not MCAS patients, but they act just like it. So long COVID is a mast cell activation type condition.
Okay. So you talked about genetic mutation. Two questions. Is there a genetic test, and is there any kind of a uh, like a diagnosis questionnaire that somebody at home could potentially kind of see, hey, could I possibly have this?
Great questions. And we didn't collaborate on this question, but perfect question. Okay, number one, it was described in 2006 by Dr. Gerhold Molderings. And Dr. Molderings took large quantities of blood out of people with these gastrointestinal based and systemic symptoms because he thought something was going along. Could something be diagnosed by genetic testing? And he found genetic markers, and he subsequently found other mutations. But these things are only found in a research lab, taking out a lot of blood from a patient, spinning it down to look for genetic changes. Um, and they differ between people. And people who are, severely affected will have more than one gene mutation. With respect to, hey, do I have MCAS? I have all these weird symptoms. I've seen so many doctors and nobody knows what, and they think I'm crazy.
Yeah.
Yeah, yeah, there's a good questionnaire. So Dr. Molderings, and then later I helped translate from Germany to the latest brand of the or latest edition of the um, mast cell mediator release syndrome um, test. And I've got that on my website, gidoctor.net, www.gidoctor.net. So that questionnaire is there. And if you have a certain amount of points, then it makes you suspicious that somebody's got a mast cell type problem. You have to do tests to really know, do they have it or not, which brings up interesting discussion between two groups of physicians, those who wanted to define it one way and one who wanted to define it another.
So let's see. So walk us through uh, patients such as Jill or somebody who's done the questionnaire and you suspect MCAS. What are some treatment options that you employ?
Well, first of all, I generally like to have a diagnosis attempt before I treat.
Okay.
But so I'll just lay out my diagnostic plan. Okay. My diagnostic test is looking at 7 readily available blood and urine tests. They have to be handled the right way because if they're these chemicals that are spit out by mast cells are heat labile. So if you spin their plasma in a regular centrifuge, then it breaks down and your levels are falsely negative. So that's number one. I like to get a positive marker, and in about 70% of people, I'll have 1 or 2, average of 1.4 positive markers, validating the questionnaire points to come up to a net sum saying this is highly likely to be MCAS. And then, in terms of the criteria to diagnose the problem, if they have symptoms in 5 or more systems, body systems, heart, abdomen, eyes, ears, nose, throat, neurological, etc., they've got a multisystemic disorder, is the main criteria. And then they have one of the following 3 abnormal chemical mediators, one of the 7, as I talked about, and not necessarily tryptase. And we could talk about that because it's so important that it's falsely thought to be a big winner to diagnose MCAS. It's not. And so then you have minor criteria of an abnormal mediator, a clinical response to mast cell directed therapy, or a positive biopsy stained for mast cells. So that's how you try to diagnose somebody.
Okay.
But like many syndromes, like irritable bowel syndrome, you get a history. You know, it's abdominal pain, change of bowel habits, some improvement with the bowel movement. It's a wastebasket diagnosis. Any number of diseases and disorders can fill that. And for any syndrome, however, like with MCAS, if you can treat, 4 mast cell chemical mediators like histamine with antihistamines, or you can stabilize the mast cells with cromolyn or quercetin, then and then they have a great clinical response. The symptoms plus the treatment improvement results in a diagnosis. And so then you can take off from there. Either A, you can label somebody who's had a disease symptomatology for years that has, driven them crazy, them upset, them depressed. Although I'm writing an article with a neurologist out of Buffalo of patients with severe depression, panic attacks, OCD, and other illnesses who were not recognized to have MCAS, had failed all psychiatric medical therapy. And when we diagnosed them with MCAS, they got better. Their brain got better. Their
Wow.
psyche got better. So that's going to be 11 patients, 2 were hers, and 9 were mine. And I'm working on that this week of vacation because I can get something done.
um, while you were talking about some of the medications, it reminded me the first time that I came across MCAS was a patient who, in depth, wanted to know about what some of the fillers or excipients were in the medications that the prescriber prescribed. And there are three key there are three main ones that I can think of that that we use or we dispense. Is one is low dose naltrexone, ketotifen, and cromolyn. And I remember going through her extensive allergies to make sure that the filler was appropriate for her. Now, is that something very important for you in your practice to kind of make sure that fillers don't cause be the trigger for MCAS?
Absolutely. Well, number one, you mentioned LDN. I try LDN on every single patient with MCAS or Ehlers-Danlos syndrome, and most with POTS because it works in many. It basically the naltrexone itself reduces inflammation and pain by working
Okay.
on toll receptors, and then probably your audience knows that it boosts endorphin levels, which reduce T cell and B cell and mast cell activation. So it can help. And in the LDN book, number two, uh, which you can find on Amazon by Linda Ellsgood. You can find that people, have response of 60%. So I looked at my first 116 patients, and 60% got better, 20% had no effect, and 20% had side effects. And sometimes it's the side effects of the fillers, but and for instance, some of my patients have allergies to pine trees, and they are allergic to methylcellulose. So that's one thing. But not only this, Jay, I will tell patients take over the counter antihistamines, and they get worse. And so then I give them loratadine and famotidine in rice flour, and they do incredibly well. So not only the standard compounded medications that you mentioned, the three, but cromolyn rarely as well. But cromolyn can be a big win because they seem to get worse because somehow the plastic leaches into the water with the cromolyn for the standard, you know, CVS or Walgreens prescription, but they can tolerate and do great with a compounding form. So not only changing readily available drugs into compounded drugs can be a big boom. These patients can be so sick with some things as minor as methylcellulose or cellulose. And so what you're doing and what you're offering in compounding pharmacies is really commendable.
Thank you. And you know what? The listeners really need to look at the packaging and the ingredients because, when something is mass manufactured, you have to consider, production machinery and what manufacturing uses is um, what works well on the machines. A penny saved on a filler when you're doing 1 million tablets, is $1 million to them. As a compounder, you're doing it in very small batches, very specific to that patient. And I tell you, in our pharmacy, we've chosen to actually use not even cellulose, but we choose to use a prebiotic fiber that we source from Germany to make our tablets. And most PCAB accredited compounding pharmacies will have a pretty comprehensive quality assurance program that where we make sure that we're buying from reputable wholesalers that provide us with a certificate of analysis and allergen statement just for patients' confidence and your confidence that the product is not causing when we're trying to help them get better. So, and that's where compounding kind of steps in. Um, Moving on, how about would you
Let
talk?
me just say, pardon me.
Yeah,
What you've just said, A, is beautiful. It tells people what they need to know about compounding pharmacies, but it's been backed up by a scientific article by Dr. Jill Schofeld and Lawrence Afrin, who presented cases of excipient-induced injury in MCAS patients who got better by going the route of changing and digging into the preparations. And another group of physicians in our study group are actually looking at the listing in the drug compendium, and there's two drug compendiums, and they're saying different things about what the excipients are. So the regular pharmacist is going to have trouble piecing this out. Um, so it really is, it's really interesting. And for those individuals out there who have 16 different allergies to medication, it's not because you're allergic to 16 drugs. That doesn't happen. You're going to be allergic to one or two fillers or
yeah,
preservatives that activate your mast cells. And so many times, and I'm sorry to say, physicians, the dummy physicians, but most of physicians are dummies, um, will look at a list of 16 allergies and the person say, she's crazy. Nobody has this. And it's sad. And
yeah.
it really is sad. But I hear this day in and day out from like patients who come in and are seen for colonoscopy. They've got all these symptoms. Yeah, that's my mast cell patient. Just ignore the fact that they have all those allergies and don't give it. And protect them, by the way, when they're having a colonoscopy and getting propofol, protect them with pre-treatment of generic Benadryl, Pepcid, Versed, and for severe problems, some salumedrol steroids as pre-anesthesia or pre-surgical approach to prevent them from having side effects from anesthetics.
So, as much as a patient, we have to consider what's in their medication. How about let's talk about diet and what they're eating. What do you recommend, like the FODMAP diet, or what are your thoughts? What do you usually recommend?
So Dr. Molderings, in his amazing article about pharmacological treatment and treatment of MCAS, said there is a golden rule, more or less, of 3-week trial on gluten-free, dairy-free, and histamine-reduced diet. So that's what I have my patients do. Ultimately, some people do well with the paleo diet, although keep in mind, if you get sick 12 hours, 6 to 12 hours after eating a meal, you got to think about alpha gal infection. So this is a IgE mediated disease, so that anytime you eat mammalian food, steak, lamb chop, or milk, cheese, off products of a cow, you're going to get terribly ill with GI symptoms. Maybe you'll have some problems with respect to itching or hives, but most of it is GI symptoms and can go unrecognized. So think about alpha gal, can run separately. I know in Virginia, you've got a lot of tick bites going on there. And one of the ticks that's all over the country now, just used to be in the South, is the Lone Star tick, which causes this autoimmune reaction.
Okay, wow. Um, all right, so how about we talk about some supplements that could give me your thoughts on good or bad to have on board with MCAS patients, okay?
Okay, well,
All right.
guaranteed is vitamin C and D. Now,
Say that again.
vitamin C and D,
Yes.
very, very important. Go ahead.
How about quercetin?
I love it. It's a flavonoid. It's what I said. It's a stabilizer. That and lutein, pure lute or other things on the market that supply another flavonoid, kind of like a cousin to quercetin, are great to stabilize mast cells.
Okay. How about DAO?
DAO, it's an enzyme that helps break down foods that you eat that are high in histamine or convert to histamine and then can't break down further. And so you're basically feeding yourself high histamines. It's its own disease, if you will.
Hmm.
To be honest with you, I think that maybe people have altered gut um, brain gut permeability issues, so they have increased intestinal permeability, lose some of the DAO and need supplements, supplementation of it. It probably helps about 5% of MCAS patients.
Okay. Okay. Because it's kind of misleading on Dr. Google about DAO. When you read it, you think you want to have it on board, but not necessarily. Um,
Correct.
all right. How about spore-based probiotics?
Spore-based probiotics are great if you're trying to treat somebody for mold. Um, if somebody has a mold problem, you're going to treat them with multiple things, but one of them is going to help to restore bacteria in the gut. It's very hard to give somebody a probiotic um, and change their whole gut flora. It's almost impossible. But there are particular lactobacilli and bifidobacter that reduce histamine output. So you have to just look on Dr. Google for probiotics that help reduce histamine output.
Okay. Let's see. Magnesium.
Magnesium, if you need it. Though you think about proton pump inhibitors. So many of my patients come to me with refractory acid reflux. And why? Because the mast cell creates histamine. Histamine drives acid levels, acid production by the cells that produce acid. So some patients have low magnesium. Some patients with MCAS, about 40% have restless leg syndrome. This is part of a study we just published in 2020. And magnesium can help some of those individuals.
Okay.
But LDN helps a lot too.
All right. How about neem capsules?
So I'll use neem when there's bacterial overgrowth. I treat
Okay.
anybody, I test people with MCAS 90% of the time to look for small intestinal bacterial overgrowth. If they have no bloating, no gas, no altered bowel habits, A, it's rare that they get to me, and B, um, I may or may not test them. But anybody with bloating, gas, change bowel habits, I want to do a lactulose breath test to see if they need either real antibiotics or herbal antibiotics.
I'm gonna go back to a comment that you made about tryptase. Could you tell us a little bit about that?
Absolutely. So Jill, who's a cartoonist, my propositist, the first patient I ever dealt with is a cartoonist, and I gave her the idea is that maybe you should have one of the 10 Commandments have something to do with tryptase. So she has Moses holding up the 10 Commandments and says underneath, thou shalt not diagnose MCAS by tryptase."
Aha.
So, in Dr. Afrin's review of 413 patients, entitled "The Characteristics of MCAS," he found that 15% had elevation of tryptase. Um, in fact, many of those patients have this genetic condition that 6 to 7% of the population has that actually doesn't cause any symptoms. It's called HAT, H-A-T, hereditary alpha tryptosemia, only recently diagnosed. So there's an extra copy of the gene that makes tryptase, but the innocent type of tryptase, it doesn't cause symptoms. So, you could have HAT and MCAS because, you're one of the 6% who is HAT and you're one of the 17% who is MCAS just incidentally. So then you'll have the elevated tryptase. The problem, Jay, is that the allergists think that tryptase has to be circulating in the blood to diagnose MCAS. They're wrong. The fact is that tryptase is a very specific chemical mediator when you have a malignancy, mastocytosis, or you've got a hereditary disorder like HAT. But if you've got tryptase levels of 20, you're going to want to get a bone marrow biopsy to see if you've got this malignant condition, mastocytosis. But the fact is, you have much less mass in the way of mast cells in the gut or in the skin or mouth than mastocytosis patients do. And therefore, you're not going to secrete large mass quantities of tryptase. So unfortunately, the they don't even the consensus one group don't even circulate or really understand their own criteria. They don't realize that in the criteria that they propose, it's elevated tryptase to a certain degree with certain change during tax or other markers for MCAS, such as N-methylhistamine in the urine and so forth. So it's unfortunately not only do the poor MCAS patients who have suffered at the hands of many physicians dismissing them,
Yeah.
but they go to an allergist who theoretically is an expert and says, well, my group says that if you don't have high tryptase, you don't have MCAS. But they don't look any further that, in fact, in those criteria, there are other chemicals. They also say that an MCAS patient has to have anaphylaxis as a historical feature, but most of our patients don't have anaphylaxis. So there's a group that started with Dr. Molderings and Dr. Afrin, and we're a group of 400 physicians that deal with this on a day-to-day basis. And we actually wrote an article in the journal Diagnosis contrasting the two criteria to make a diagnosis. So the saddest thing is that I think that people are making it harder to diagnose so they don't have to take care of these sick people.
This is a great time. If you could talk to us about the documentary that you are trying to publish, if you could talk to us a little bit about that and your passion behind it to getting it out to the public.
Thank you for taking that time and letting me talk for a couple minutes. We are doing the first MCAS documentary. We're going to add to it the evil triad, POTS and Ehlers-Danlos. And we're going to add to it the common triggers such as Lyme and mold. And we're going to look at individuals who we have diagnosed and treated and who have survived and thrived just by making the diagnosis of MCAS and POTS and EDS. It's hard to imagine missing it, but it's missed all the time. So we want a positive message. We're going to start filming in December. We're trying to do a fundraising. We're also going to do something that nobody's ever done before. We're going to have a bunch of lectures basically that are attached to the movie by QR codes or hard links on YouTube that will be lectures by some of the best physicians around who really are delving deep into these three syndromes and the triggers. And we hope so that people with open minds, like the naturopaths and the integrative physicians, will be able to arm themselves with education. And so in December, we're going to start on this journey. We're going to start filming. So the LDN Research Trust is becoming our fund, our charity fund to collect, because this is a nonprofit thing. Nobody is going to make money. We want to make a great product to educate the public, to educate the family and the patients, and to bring it to the attention of the younger, more open-minded medical providers, such as medical students, naturopaths, nurse practitioners, physicians assistants, etc. So we're looking for donations. So it's basically MCASfund.com, MCASfund.com. If you got $20, it'll help put this forward in gear. It costs a lot to do a documentary, but what we're doing is not just a little film. This is going to be something that we feel will contribute to the health and well-being of so many patients afflicted by these syndromes.
Well, Dr. Weinstock, thank you for sharing that. I'll make sure to put the website address on the mcasfund.com in our show notes. I want to truly thank you for joining us today. You shared a lot of great information. Also, regarding the questionnaire, I'll put your website in the information notes for those that wanted to go and kind of download the questionnaire. And thank you, everyone, for tuning into the Compounding Center Connections podcast. We hope you found the information presented to you today to be helpful. If you have any comments or questions, feel free to reach out to me at jay@compoundingcenter.com. Subscribe to our YouTube channel and our podcast channel, The Compounding Center Connections, and stay tuned for future episodes. Thank you, Dr. Weinstock.
Thank you, Jay.